we are live in session.
Perfect, thank you. I think Kim was going to give a bit of a housekeeping introduction, and then I'll get started. Hi, everyone. Welcome to the Spotlight session today on new and innovative data uses at ICES. We have three very exciting speakers today who are all going to speak on a different new and innovative data use at ICES. To begin with, we're going to have Dr. Kirsch, who's an epidemiologist with the Ontario Health Study and an assistant professor in the Dolly Lana School of Public Health at the University of Toronto, give a talk on the Ontario Health Study, a resource for cancer, disease, health research in Ontario and Canada. Following Dr. Kirsch, Dr. Salima Sharif, who's the Associate Director of Research Operations and Strategic Partnerships at ICS Western, a staff scientist at ICS, an associate scientist with the London Health Sciences Centre Research Institute, and an adjunct research professor in the Faculty of Health Sciences at Western University. She's going to be presenting on identifying individuals with a recent experience of homelessness using ICS data. Our final presentation is going to be by Allison, who's a senior epidemiologist at ICS and has a background in epidemiology, specifically perinatal epidemiology. She currently maintains the ICS-derived Ontario Mum-Baby linked dataset and is the content expert for Mum-Baby and the Better Outcomes Registry and newborn data at ICS. So today she's going to be presenting on perinatal data. We're going to begin with the three presentations. Following the three presentations, we'll open the floor up for discussion and for questions. So we do ask, if you have questions, please put them into the Q&A chat as the presentations go, but we will be holding off until the end of all three to begin. So I'm going to turn it over now to Dr. Kirsch to begin her presentation.
Great, thanks so much. Hi, everyone, and thank you all for joining today. I'm going to be talking about the Ontario Health Study and the ways it can be integrated with ICES data holdings to serve as a resource for health research. So what is the Ontario Health Study? It's a longitudinal population-based regional cohort study, and it's a resource for investigating the ways in which lifestyle, the environment, and genetics affect people's health. To do that, we recruited about 225,000 participants aged 18 and older and consented them online to participate in the study. The OHS then makes that data and our samples available to researchers. And the intent is to follow participants through active data collection and administrative data linkages for the rest of their lives. And they were actually celebrating 15 years the first participant registered for the study. Both diseased and healthy individuals were eligible for inclusion. As time went on, some people developed disease, some people died, and some people remain disease-free. The prevalent cases support cross-sectional analyses, and the incident cases prospective analyses. And then given the blood study also provides an opportunity to study environmental interactions. The linking then of Canada's rich collection of administrative health data cohort expands the amount of data available. So data from about 83% of OHS participants have been successfully linked to these administrative health records. So this means that they've already been assigned an ICES key number or IKN, which will expedite any new research projects. So we linked to a large array of these health records at the end of 2021. Some of them are ready to go, or they just would an update for a research project. So these linkages with the administrative health-related data sets by nature allow passive follow-up of participants for future disease endpoints, as well as an array of clinical data, so to health services research. Why is it important? 3-5 adult Canadian chronic disease, the healthcare costs are enormous. 1 in 2.2 Canadians will develop cancer in their lifetime. So the research platform is particularly important because Canadians are living longer, are more likely to be diagnosed with multiple conditions. And, any insight into how these conditions, the pathology or how they interact with the healthcare system is, of course, important to prevent some of these conditions and delay their onset by years. The impact on both the healthcare system and quality of life would be substantial. In terms of the data that the OHS has been able to share with researchers, we've collected multiple online questionnaires, plus the majority of the cohort has been linked to administrative health databases, and a subset provided by specimens and physical measures. And we expect genetic data available for almost 40,000 participants within about a year. And about 20,000 are currently available. The OHS also supports ancillary studies where we help other studies recruit OHS participants to be part of their own research projects. So through these type of collaborations, we also have MRI and cognitive data, about 3,000 participants. And then finally, since the plan is to follow participants indefinitely, continue to collect data biospecimens over the coming years. Here's a timeline of our data collection, beginning with recruitment in 2009. At study, cohort members completed a questionnaire that collected information on sociodemographics, family health history, health status, behavioral factors, lifestyle factors, for example. And then follow-up questions were administered after that with a work history questionnaire in 2019. And COVID questionnaires and serial dried blood spots were collected from 2020 to 2020. The mean enrollment was 40 and ranged from 18 to 97 years. The blue bars here represent the OHS data. So compared to the Ontario population aged 18 or and the study population is a little overrepresented for women, underrepresented for minority populations, and a little overrepresented for those with a university degree and those at higher income levels. In terms of the geographic distribution, the study population is geographically diverse with proportional representation from urban and rural areas across each of Ontario's public health units. So the darker the color here, the greater the number of participants. So you can see we have a large number of participants from Toronto and Ottawa, for example. With respect to the biospecimens available for access, we have aliquots of plasma, serum, red blood cells, buffy coat, lymphocytes, and DNA has been extracted from a large number of participants. And then we have up to 3 dried blood spots from under 10,000 participants. And then the bottom half of the slide summarizes some of the data that's already been generated from the biospecimens. So there's some immediate blood analysis that was done, genotyping, sequencing, and then through our serology studies supporting COVID research, we also have antibody measurements at these multiple time points. So that could support research, for example, into long COVID. We also have data on medication use, and that's something that's not captured population-wide through administrative claims, so really represents sort of a gap that could be filled using the OHS data. About 40% of our participants indicated that they were taking a medication, and among the top 10 frequently prescribed medications were those for hypothyroidism, high blood pressure, and asthma medications, for example. So when participants provided the DIN to us, this was linked to a database provided by Health Canada. And so we have the drug codes, we have the brand names of the medications, and we have the ATC codes for each medication. And as I've mentioned, about 83 participants have already been linked to the ICES data holdings. And these are some of the databases that we've already linked to or have ability to link to. So it includes the cancer registry that's held at ICES, vital statistics, lab test results through OLIS, and all of the other disease registries that have been created and validated at ICES. So with these linkage results, researchers can analyze health outcomes and also conduct health services research. These are some of the results of our linkage, showing the most prevalent, the most common and incident diseases. The blue bars represent the prevalent cases and the orange bars represent the incident cases. So not surprisingly, we see hypertension and coronary artery disease leading the way, with good representation from respiratory diseases, diabetes, and different types of stroke. And this table reflects the linkage of participants to the cancer registry through the end of March 2021. On the left side, you can see the most common prevalent and incident cancer types. And then on the right side, we've restricted it to just those who provided blood. So not surprisingly, breast and prostate cancer are the most common cancer types for both prevalent and incident cases. And then before Omicron hit and sort of overwhelmed testing capacity, we were able to ascertain COVID-19 cases linkage with illness. So the blue bars show the number of tests that were performed, and then the red line shows the number of new cases per week. And really, this epidemic curve did mimic that in the population as a whole up until sort of pre-Omicron. And then post-Omicron, we have our study-specific blood samples and self-reported cases. And then finally, final linkage opportunity with CANUS, which stands for the Canadian Urban Environmental Health Research Consortium. All OHS participants have been linked to the database, which captures environmental exposures, including air quality, nearby traffic, access to green space, walkability, social deprivation, climate, and weather. And we partnered with Statistics Canada through what's called the SDLE program, whereby the participants' previous residents were reconstructed through this initiative using data from federal documents. So we have a whole history of residents that can be then environmental indicators. And this serves as a platform to study change impact on health, for example. So how to apply to access the data? There's a process for ICES scientists and one for those who are affiliated. They're very similar, but I've outlined one for scientists here. Basically, all we need is a protocol, proof of funding if you have it, a CV, and an RE letter to get the ball rolling. And then this will be available sort of consult the process in more detail later, or visit the OHS website. And finally, I just wanted to mention that the OHS is actually part of a larger national cohort called Canadian Partnership for Tomorrow's Health, or CANPATH. And that included from over 330,000 participants across provinces, with us contributing over half of the data. Next, for the OHS, we're ramping up our outreach to the scientific community. So please reach out if you'd like to be added to our distribution lists. This year, we're back in the field to resume blood collection from a subset of participants. We have some ancillary studies that are in the works. And finally, data collection is continuing with the second follow-up questionnaire and a diet and physical activity questionnaire. So our funders are OICR and the Canadian Partnership Against Cancer. And finally, a shout out to all participants who make all of this possible. To learn more about the study, we have a profile paper that was published in IJE last year. And you can email us or check out our website. Thanks so much.
Great. Thanks, Vicki, for that. In the next few minutes, I hope to provide a general overview of how to identify individuals with a recent experience of homelessness using administrative data at ICES, and some considerations surrounding the use of these data. I want to start the presentation by putting us all on the same footing and reading the Canadian definition of homelessness as established by the Canadian Observatory on Homelessness. Homelessness describes the situation of an individual, family, or community without stable, safe, permanent, appropriate housing, or the immediate prospect, means, and ability of acquiring it. It is a result of systemic or societal barriers, a lack of affordable and appropriate housing, the individual or household's financial, mental, cognitive, behavioral, or physical challenges, and or racism and discrimination. Most people do not choose to be homeless, and the experience is generally negative, unpleasant, unhealthy, unsafe, stressful, and distressing. I'm going to pause so that everyone can reflect on these words. Based on this, I hope that everyone agrees that homelessness is a complex societal issue with a variety of underlying economic, social, and structural factors. Homelessness also directly impacts many of us. A recent Nanos poll by the Canadian Alliance to End Homelessness revealed that 1 in 20 Canadians report experiencing homelessness at some point in their lifetimes. 1 in 10 know a family member who has been homeless, and 1 in 5 know a friend or acquaintance who has been homeless. Combined, the poll found that 1 in 3 Canadians have been homeless themselves or know someone who is homeless. As a social determinant of health, housing, or lack thereof is inextricably linked to health and well-being. As such, people experiencing homelessness have high levels of morbidity and are at risk of premature mortality. For example, in 2022, the median age of death of people experiencing homelessness in Toronto was 55 years for males and 42 years for females, contrasted to the average life expectancy in Canada at that time, which was 81 years. Although as a health system, we don't do a good job of collecting information about social determinants of health, there have been increased efforts to recognize and collect information about homelessness during hospital-based encounters in Canada. In 2018, the Canadian Institute for Health Information updated their coding standards, making it mandatory to include a diagnosis of homelessness in the administrative data record if an individual was homeless on admission. The rationale for this coding change was that tracking healthcare usage by homeless individuals is important to understanding initiatives aimed at reducing homelessness. These standards have continued to evolve, with the most recent update indicating that homelessness should be recorded wherever documented in the patient's medical record. Beyond just the DAT and the NACRs, at ICES, 2 other data sources also collect information on homelessness. These are the Ontario Mental Health Reporting System and the Community Health Centres. For those not familiar with the Community Health Centres, or CHCs, they are not-for-profit community-governed organizations with a primary focus on improving the health and well-being of populations who have traditionally faced barriers accessing health services. It is important to note, unfortunately, that OHIP does not collect information on housing status, and therefore this information is missing for most outpatient healthcare services in Ontario. And like all administrative data, data on homelessness have their limitations. First, we're only able to identify those experiencing homelessness who have a valid health card, and by doing so, we exclude groups that are often overrepresented among homeless populations, such as refugee claimants. Second, in order to be recognized as homeless in our data, individuals must have accessed care at a hospital or a CHC. And while accessing care, they need to be recognized as experiencing homelessness. I included the word recognized in quotes because it's unclear whether an assumption is made about someone's housing status or if they're asked to disclose or confirm their housing status. Further, those who are provisionally accommodated, such as living temporarily with friends or family, may not identify as homeless, although their housing condition would be captured under the Canadian definition. Fourth, these data are not precise enough to differentiate between chronic or episodic homelessness. And finally, the data also do not provide any detail about the physical living conditions, also known as the typology of homelessness. Shortly before the COVID pandemic was declared, our team at ICES Western published the results of a validation study of these data. We found that the data have low to moderate sensitivity at capturing homelessness. However, the data were found to have excellent specificity and positive likelihood ratios, indicating that where an indicator is present, an individual most likely recently experienced homelessness. I received a lot of inquiries about using this algorithm, so thought I would take this opportunity to share our learnings. First, we found that the algorithm is most appropriate when creating a cohort of individuals with a recent experience of homelessness and ideally evaluating this single group. And given the limited sensitivity and high risk of misclassification, particularly depending on the underlying population, caution should be taken when using the algorithm to define a baseline characteristic. And similarly, caution should be taken in including this concept as a covariate in model adjustment, as it may incur further bias. It would also not be appropriate to use the algorithm to make statements about the start and end of episodes of homelessness, as these data lack specificity, as discussed in the limitation slide earlier. Next, if using a large window of data to define a cohort, it would be most appropriate to refer to the population as having recently experienced homelessness versus experiencing homelessness. Third, and quite importantly, would be to acknowledge the limited generalizability and to refrain from overstating the sample's representativeness, or to interpret the findings without considering the limitations of the sample and underlying data. And finally, where a study is considering house comparator groups, we would recommend carefully thinking through options for defining such groups to minimize the potential for selection bias. To bring this all together, I thought I would share how our team has used this algorithm. In this paper published just a few weeks ago, we sought to compare the prevalence of dementia among people experiencing homelessness to presumed house populations in Ontario. We did this by first identifying all instances of a positive homeless indicator in a one-year period, then looked back in time to determine if these individuals had received a dementia diagnosis. In selecting our comparator populations, we tried to apply the same selective forces by restricting to those who had accessed only the same healthcare services that we used to identify people experiencing homelessness. We further undertook additional analyses to assess the potential for selection bias in our findings in order to inform our interpretation. And here I have just presented the prevalence rates that we found among those with early onset dementia, where it is apparent from the descriptive depiction that those identified as experiencing homelessness had higher prevalence of diagnosed dementia in this younger age group. So I hope that provided a general overview of identifying individuals with a recent experience of homelessness using health administrative data in Ontario and some considerations on the use of these data. I would be happy to take questions during the Q&A portion of this session. And I will turn it over now to Allison, who's going to be talking about the various perinatal data sources available at ICES.
Thank you, Salima. Okay, so I'm going to talk about a couple of the perinatal data sources at ICES. So I'm just going to start with a brief overview of the data, talk about some of the agreement that has been assessed and also applications of the linked perinatal data and how to access the data. So the two main sources of perinatal data at ICES are the CIHI Discharge Abstract Database, which most of us are familiar with, and also the associated mom-baby dataset, which links mothers and babies from CIHI DAD, as well as the Better Outcomes Registry and Network data, which consists of the NIDA perinatal database and the Born Information System at ICES. So the CIHI DAD is administrative, clinical, and demographic data about all hospital inpatient discharges. And at ICES, we have Ontario data from fiscal 1988 up to the last quarter. And some of the variables that are most relevant to perinatal research are diagnosis and intervention codes, birth weight, gestational weeks, sex, parity, as well as other fields. The mom-baby is a data set that's derived at ICES by linking the CIHI DAD maternal delivery records to the newborn birth records. And right now it consists of almost 4.5 million maternal infant records. So this graph just shows how the linkage between mothers and infant records and CIHI-DAD has increased over time, especially since 2002, since we have received the maternal infant chart number, which is part of DAD. And the linkage is well over 95% for the years since 2012. So the second major source of data for perinatal research at ICES is the Born Ontario data. So Born collects pregnancy, birth, and newborn data to facilitate perinatal care in Ontario. Born is funded by the Ministry of Health and supported by Children's Hospital of Eastern Ontario. The two sources of data that we get from Born are the NIDA perinatal database, which is from fiscal 2006 to 2011. And it contains about 800,000 births and has about 100% coverage as of fiscal 2010. The BIS data starts in 2012 and currently goes up to 2020, but we are slated to receive annual updates. And right now it consists of about 1.3 million maternal and infant records. In addition to birthing hospitals, BIS data also contains data from fertility clinics, birthing centers, midwife practice groups, as well as prenatal and newborn screening labs. And I also just posted a link below to a data resource profile about the Born data in the International Journal of Epidemiology. It provides a nice overview of Born data. Some of the notable data elements that are part of Born that are not available or not as well recorded in administrative data are self-reported and diagnosed health behaviors and health problems such as mental health, smoking, alcohol and drug use, maternal weight and weight gain in pregnancy, assisted reproduction, prenatal, as well as newborn screening, vaccines, antenatal care provider, and some other newborn information like APGAR score and infant feeding as well. So recently, we published a paper comparing BIS and CIHI-DAD, looking at the agreement when identifying a low-risk birth cohort using both data sources. So we used data from April 2012 to March 2018, and we ended up with almost 780,000 linkable births between those two data sets. We then compared the portion of the linked cohort that met each of the exclusion criterion of the low-risk birth definition. And then we compared the rates of some clinical outcomes like cesarean section and ICU. So just a very high-level overview of the findings. I'm not going to get into any numbers at this point, but basically we had high agreement for most of the criteria, including parity, gestational age, stillbirth, diabetes, hypertension, as well as placental disorders and fetal complications. However, BIS does identify more pre-existing conditions. So some of those pre-existing conditions that are part of the low-risk birth cohort or their low-risk birth definition are pulmonary, musculoskeletal, neurologic, cardiovascular, cancer, etc. So these conditions were picked up. Were picked up better when using BIS compared to using DAD. Also, BIS captures some other information that's not directly captured in DAD. So labor type as well as fetal presentation tend to be better captured in BIS. And then after applying the low-risk birth exclusions, the prevalence of cesarean and ICU were found to be slightly higher when using BIS than using DAD. So just some conclusions and general recommendations. So either source can be appropriate for surveillance and research, but it depends on your study question. It's important to understand the differences in the collection and the coding of the variables and the differences between the data sources. However, if you are looking to perform longitudinal studies or multi-jurisdictional studies, CIHI-DAD is going to be almost always necessary, given the long range of data that's available there, and the fact that CIHI-DAD is collected across Canada in a very similar way. That said, linking born and CIHI-DAD, as well as other ICES data, can provide unique opportunities to study perinatal outcomes. And just some examples in recent years. So some studies have looked at acute care related to cannabis use in pregnancy. So cannabis would have been available from the board data. Disability and in-hospital breastfeeding practices. Exposure to epidural and autism spectrum disorder in offspring. Pre-pregnancy weight gain and gestational weight gain, and allergic disease in offspring, as well as infertility treatment and postpartum mental illness. These are just some examples of studies that have combined born and ICS data. So for data access, there are no special pre-approvals required to use CIHI-DAD or MomBaby. If you're a third-party researcher, you can access this data as well through ICS data and analytic services. And for born data, it does require pre-approval, and that would come from the ICS Director of Strategic Partnerships, as well as born. And that the process involves submitting a project initiation form and your proposal, and then you would get approval after that. Currently, born is not available for third-party research, however. So I'm going to stop there, and I think we're going into questions next, so I will pass it back to Erin.
Thanks very much, Allison, and to all the presenters today. You really highlighted a number of great uses of some novel data sources at ICS. So we'll open it up now for questions. If anyone has any questions, I invite you to add them to the question and answer chat there, and we can get started. Maybe I'll start with the first one while we're kind of waiting for others to add their questions to the chat there. The first question is for Dr. Kirsch, and if you could kind of highlight maybe what one example of a study is that's using Ontario Health Study, whether that's linked with ICS data or not, to kind of give the audience an example of one study or several studies that have been a product of this study.
Sure. I mean, we have there are some studies that have made use of the biospecimens to look for protein markers, and they found that there are certain markers that are predictive of breast and prostate cancer years before a diagnosis, for example. There are other studies that have just been made use of the cross-sectional data and looked for at green spaces, green noise, and a risk of depression. And then there are ongoing studies looking at risk of lung cancer among non-smokers, for example, looking at some of the fine particulate matter, and some of the dietary information we have as well, and risk of lung cancer.
Thanks very much. We have the first question in the chat here, and that's from Laura. It's also for you, Dr. Kirsch, and that's, I may have missed it in your presentation, but do you have ApoE genotypes in the OHS data?
We're just starting sort of it was targeted genotyping that was done. I'm not 100% sure, but I can look into that.
Perfect. Would it be okay if we asked Laura to connect with you
Sure.
After this presentation?
Sure.
Wonderful. Thanks so much, Laura. Are there any other questions from the audience that you want to add to the Q&A? Seems that all of you have covered everything very eloquently in your presentations, and and there's not a lot of questions. We'll just give everybody a few more minutes to see if anyone has any additional questions, or if any of the presenters have anything that they wanted to add. Salim, I know that you highlighted the one study that's used the ICES homelessness algorithm around dementia. Mm-hmm. Do you have any other ideas for potentially future research, or other ways that you're hoping to use the homelessness algorithm at ICES?
Yeah, thanks, Erin. So we've already published a few studies using the algorithm. It actually really started to ramp up around COVID. So we started the work in that area really early on, where we were showing the differential in COVID testing, infections, hospitalizations, and complications just during the first wave of the pandemic. And then that followed by looking at vaccination rates among people experiencing homelessness, which we were very fortunate to be able to present given the access to the vaccination data that we received. That then in that same theme followed a few months later, actually almost 2 years later, looking across the first few waves up until Omicron. And again, now seeing, after that initial understanding of the differential and in the infections and complications, whether that had changed over time. And unfortunately, it hadn't, and we'd seen, a really large differential during Omicron for COVID infections and complications among people experiencing homelessness. We've also worked with other teams that have looked at hospitalizations for things like mental health and mental health illness and opioids and other substance uses. We've worked with the Ontario Drug Policy Research Network and Tarragona specifically to try to understand the burden of opioid-related deaths among people experiencing homelessness, where we found that 1 in 6 opioid deaths were among people experiencing homelessness in the most recent available data. That was up to 2021. We have a few other studies underway right now. One is looking back to the dementia topic, really trying to understand what happens around the time of a diagnosis of dementia. As you can, imagine, being homeless and also experiencing dementia would be quite challenging. And then we are hoping to understand whether these data can be used to look at the change in the circumstances and the portrait, like the demographic characteristics of homelessness in Ontario. And so that work is underway. So yeah, there's a lot going on and lots of great ideas that are out there. And as I said, just kind of caution to using these data and making sure that we're not overstating things.
Thanks very much, Dr. Sharif. We have a question now for Allison. It's from Catherine Muldoon. What are the main challenges with linking Born and the Mum Baby or other perinatal databases at ICES?
So I think that the linkage between Born Biz and Mom Baby is quite clear cut. We have in both of those databases, we have the maternal and the infant health card number, so they're very easy to link back and forth. With the NIDA data, it was not received with, it was received with the baby's information, but not the maternal information, which made it challenging to link stillbirth records, because quite often stillborns won't have a valid health card number attached to their record. And so some of the NIDA data was more challenging to link. But the BIS data is quite simple to use and to link to not just mom, baby, and dad, but all other databases that have that health card identifier. I hope that answers the question.
Thanks very much, Allison. We have another question that's open to the whole panel, and that is, what are some of the challenges you faced in using new and innovative data at ICES?
I'm happy to start. I did talk about a number of our limitations, and I think the biggest challenge for us really has been to try to understand the validity of the data itself, what individuals we're capturing with these data, and who we are not capturing. And so then to have to be really careful about how we frame our interpretation. There's also been coding changes over time, and so that has also impacted the validity and reliability of the capture over time. So a lot of time was spent really, working through some of those quality issues, and we continue to do that at each time we run a study, because there's always something new that's brought to our attention.
And I think, for the OHS, while we did have success in linking, it wasn't 100% coverage. So we were only able to link about 83% of our participants. Some of them didn't consent to linkages, but some of them, it was just, we rely on holistic linkage, which isn't perfect. So that does reduce our sample size a little bit. And then, obviously, we have this self-reported questionnaires, and then we have these administrative linkages so that we're able to sort of compare and contrast that. Sometimes we need the two, like, for example, when we were ascertaining COVID diagnosis, a linkage to OLIS was useful, but only up until a point. When other testing modalities came in and people were doing home testing, we need to rely on our dried blood spot cards and self-reported tests, for example.
Thanks very much. The next question we have here is from Sarah Carsley, and I think maybe it's best addressed by Allison, or maybe we're going to have to kind of take this back to strategic partnerships. But are there any conversations happening about linking the healthy babies, healthy children data at ICES? I'm not aware. I haven't heard about any conversations about that, but that would be a good question for strategic partnerships. I can take that back to them. Sounds good. Thanks so much, Allison. We have another question. I think this one is for Dr. Sharif, and this is around the CHI-HI-DAD. There used to be a variable in CHI-HI-DAD to capture homelessness, but I don't think that it has been there in recent years' data. Was this ever part of the homelessness algorithm? And if so, how did things get adjusted to account for this?
Yeah, thanks for that. So our validation work was done in 2016, and that variable, if I recall, was not even available at that time. It was no longer being used. And so the two sources that we were using, and I'm just looking at that next question here about whether ICD-10 for Z590 and Z591 are the only two diagnosis codes that we use. So we did use both of those. Practice used to be that if an individual came to a hospital and did not have a fixed address, they would actually use an XX as a postal code, and that was a way of identifying people who did not have a permanent address. And in some cases, hospitals would use their own postal code and just place it in there for the patient's record. Those are no longer the practice, and therefore are not included in our algorithm.
Thank you. I think you've addressed the next question as well, but I'll read it out loud just so that everybody's aware the question's been asked. And that's, does the ICES algorithm for homelessness include variables other than the ICD-10 code for homelessness? So Z759.0 and Z759.1. Okay, we have another question. This one's also for you, Dr. Sharif. There seems to be a lot of interest around homelessness. This is from Christina de Jong. I may have missed it, but I know why the homeless algorithm can be used for cohort creation, but not to be used to define a baseline characteristics or covariate.
Yeah, so that's really because of the significant misclassification. So we have very poor sensitivity. It was, peaking at around 30% before the change in coding practice, and some preliminary work has shown that that's maybe increased to about 50%. And that's really homelessness over a period of time, so recent experience of homelessness. And so if you only have 50% misclassification, then if you are comparing between, say, exposure groups, you don't really know whether that's differential, non-differential. And so presenting it as a baseline characteristic and maybe providing a standardized difference or a p-value can really be misleading, because we don't know what we don't know, really. And similarly, with a covariate, with a variable that has so much misclassification, again, not knowing whether it's differential or non-differential can really impact the values that you get and the estimates that you get in a model. So I couldn't hear you there, Erin, but I'm presuming that you're reading that next question there about the algorithm. And the question was, are we able to identify people along the spectrum from absolute homelessness to more transient periods of housing? And if we expect there's a differential captured by gender? So, it's a fantastic question. We have very limited availability of data or cohorts of individual where we can even capture this information through primary data collection that we would then need to bring into ICES and link to do some validation studies around whether we are or aren't capturing this. And so we really suspect that we're biased towards people who are probably more chronically homeless and those who have trust in the healthcare system and therefore are actually using the healthcare system. Hidden homelessness or people who are provisionally housed are most likely not captured in there. Individuals who may be transiently homeless are probably not also captured in there, because then the expectation would be that they access health services at that time, they recognize themselves or they identify themselves as experiencing homelessness. In terms of the differential captured by gender, we didn't notice that in our initial validation study, but we do know that the typology and the circumstances around homelessness do differ by gender, and so I do suspect that we're probably less likely to identify women. But again, that is really just my speculation at the moment, and would be something that we would focus in on if we had the opportunity of updating our validation study using a more representative sample, and ideally something that is across the province, including individuals living in rural geographies of Ontario.
Thanks so much. I'm not seeing any additional questions in the Q&A chat, so I'll open it up one last time to see if anyone has any final questions for the presenters. We're nearing the end of the session, so if you have any questions, please add them in there. And of course, you have the contact details for Dr. Sharif, Dr. Kirsch, and Allison as well. So please feel free, if a question comes up after the session, to reach out directly.
I just wanted to
go ahead.
Come back to Laura's question about the genotyping. So we've genotyped about 20,000 participants using the UK Biobank array from Affymetrix, which does include the APOE genotype.
Wonderful. Thank you so much for following up on that. Okay, not seeing any other questions. I think we can wrap up the session. Thanks very much to all three presenters. We have some really exciting novel data being used at ICES. These are three examples that we've highlighted, but I know across the network we have several examples of new and innovative data that we're capturing and that we're linking to ICES data that are being used for a variety of different studies. So I encourage you to, always be, looking at the newsletters that are coming out from ICES and looking at the data dictionary for some of the new and exciting data that we're linking. I see one additional question has come in here. We have a couple minutes. So are there any discussions about linking data sets without the use of RPDB so that the need for OHIP number is not necessary?
I think that's a great question to maybe take back to Mahmoud and his team and see if that's something that's in the works. But, I can speak from our experience that would be very valuable because there are a number of people experiencing homelessness who don't have a health card, and some individuals who also misplace their health cards and so may not be also captured when they seek health services.
And we do have ways linking individuals when, you know, the OHIP number is incorrect or when we have a missing OHIP number. So I think I agree. DQIM is really the best department to discuss, you know, your options for this. If you have some data that you're looking to bring that doesn't have OHIP number to ICES, I would encourage you to get in touch with Mahmood and discuss whether or not, you know, your potential data set has an ability to be linked to ICES without that OHIP number. So that concludes our session. I hope everyone has a wonderful lunch break, and I remind you that you're welcome to join one of the virtual lunchrooms if you would like to network or chat with some other attendees. There's a widget to access the lunchroom in the main menu. So we look forward to welcoming you back for the keynote with Dr. Tara Kieran at 1 p.m. So again, thank you very much for all of your insightful discussions, and I hope you enjoy the rest of the day.